my lesson plans, and I'm writing and I'm writing and I'm writing and I'm going, oh my God, how are we ever going to get through all this? Okay? Yeah. So I'm trusting that you have done your reading. Okay? And I'm going to go over a few concepts that they talk about in the book, and then we're going to do some activities that hopefully will bring everything together in preparation for Monday. Okay? So what I want to go over is on page here we go. Well, I don't know what page. Let me find it. It's where they talk about the different biases. Okay, here we go, page 450. We're in box 15.4. Okay, after a back injury, in the general stages of recovery, acute phase is going to last for 0 to 4 weeks, similar to what we've always done. And that's acute. They break it down into acute with inflammation and acute without inflammation. Without inflammation, they'll have intermittent symptoms with acute nerve root symptoms. Okay, so that's more of a mechanical type injury than an acute inflammatory injury. Okay? Subacute goes from 4 to 12, chronic greater than 12, and then chronic pain syndrome is greater than 6 months. Okay? And based on what happened with the last test, chronic, just because you see the word chronic, doesn't mean 6 months or greater. Chronic, when it's associated with pain, is 6 months or greater. Chronic just means it's been there for a while, in general terms. But when you attach it to chronic pain syndrome, it means pain that's been there for greater than 6 months. Just to clarify that. Now, when you're looking at back problems, I like the way that Kisner attacks that. Because she talks about movement biases. The first one she talks about is a non-weight bearing bias. And basically what that means is that during the acute phase, people are unable to be in a position of weight bearing. So sitting is painful, standing is painful, walking is painful. So in the acute phase, you really have to take a person out of their bias position. So with somebody with a non-weight bearing bias, have you got that thing going? Okay. Somebody with a non-weight bearing bias, they have decreased pain with traction. So traction is a good thing to do with these people, whether it's in the neck or the low back. What else do we know that reduces pressure on the spine?
Swimming.
Yes, aquatics. So they can do pool treatments. Assuming they have no open wounds from, maybe from trauma or whatever. But they can do aquatics. They might respond to wearing an abdominal binder that increases the pressure, abdominal pressure, and takes weight off of the spine. Okay. They may be able to do some walking on a treadmill suspended so that they get a distraction of the spine.
Would that be walking on the treadmill in the water?
No.
Or just, because I know it sounds dumb. but
Like
they
on an
have
incline?
water.
No, they would be suspended. Have you
Yeah,
seen,
okay.
have you seen
what
the treadmills and walking systems where they put you in a harness? Okay, so they put you in a harness to take weight off of your legs, but yet you can walk.
So like eliminates gravity?
Yeah, well, it eliminates gravity and it distracts your spine. That wouldn't work for the neck very well. Just saying. But it would for the low back. So they don't tolerate being upright for basic ADLs and IADLs. What are IADLs? Instrumental activities of daily living. And what do those include?
Cooking, cleaning.
Those are basic ADLs.
Oh.
Cleaning kind of gets into IADLs, but community type activities, so shopping, going back to work, those kinds of things. They really can't do any testing that we want them to do because they're so acutely in pain. Okay, so minimal testing can be done, and we talked about traction relieving the symptoms. Now, as they get better and move into chronic, or move into the subacute stage, you can start doing a little more weight bearing because their pain will have decreased a little bit. And eventually in that chronic phase, you're going to be able to do more normal type activities. But when they're acute, you've got to get that weight bearing. You got to move them outside of the weight bearing activities. Okay, with an extension bias, you're going to use an extension approach. So an extension bias means that when they go into extension, their symptoms lessen or they centralize. An extension bias is usually a disc problem. Because what happens with extension? It moves that disc material anteriorly. So if you have a disc bulge or protrusion and you extend, it tends to pull that material out of, back into the disc space. Okay? Yes?
Can it possibly pinch it though if it's out?
If it's out too
Is
far,
that
if
enough,
you've
I
got
guess?
an extrusion,
Oh,
you
okay.
won't be able to do
So
that.
it's-
So in the acute phase, you're going to teach people how to maintain that extension in their back or their neck to keep the pressure forward, keep the pressure anterior, move that disc out of that position. So when they're sitting, they need to have a lumbar roll in place. Okay. when they're laying in bed, they may do better on their belly than on their back because of the position of the back. Now, in your catalogs that I gave you, there's a device in there that's a round pillow that you wrap around your waist. And some people find that sleeping with those keeps that lordosis in their back and is more comfortable than sleeping without it. If they have an extension bias with a lateral shift, which direction are they going to shift? Towards or away from the lesion? Away from the lesion. So your task is to bring them back into or out of that lateral shift and then do extension with them. Okay? So some of the things that you might do is have them lie prone and maybe prop up prone on elbows, because that gives them a passive extension stretch. But you've got to correct that lateral shift first before you go into extension. Repeated flexion in these people will peripheralize their pain and their symptoms. So it'll move down their leg or out into their upper extremity. And extension will centralize it. Centralizing the pain is a good thing. Peripheralization is not a good thing. Okay. So then there's a flexion bias. And these people prefer to be in a flex position. These are people who have spinal stenosis or spondylosis or spondylolisthesis. Do you remember what spondylolisthesis is?
It's the forward
Just
steps.
the forward
Yeah.
for the.
It's when one vertebrae slips forward relative to another. And usually they have spondylosis before they have listhesis. Usually it happens at the sacrum and L5. Because of the angle of the sacrum. Okay? So you lose disc height, you start getting lipping at the margins of the vertebrae. You might get some osteophyte formation, bone spurring, and then at some point, this vertebrae will slip forward. The risk there is the spinal cord or the cauda equina getting impinged because this one slips forward, but this one doesn't. Yeah, you would not want to do extension with this problem. And why would that be?
Push it further.
Yeah,
It's going to push it further, isn't it? So you really want to focus on flexion with these people. The other problem would be people with facet joint arthritis. Because what does extension do? Put the pressure on those facet joints, doesn't it? So when you see these people in the acute phase, you're going to want to try to keep them in flexion. So sitting feels better to them. Lying down with their knees bent up feels good to them. When they're in bed, Having pillows underneath their knees feels better. Side lying with their knees bent up and a pillow between their knees feels better. Okay. Then there's a hypermobility and instability syndrome. Now they may be hypermobile at a segment or several segments, and they have poor spinal stability. Their diagnosis may include trauma, ligamentous laxity, spondylosis or spondylolisthesis. So there's kind of an overlap there, isn't there, with the flexion and the hypermobility. And you'll want to teach them stabilization right away. You're going to teach them how to stabilize as they're moving. We're going to go over that, how to stabilize when you move. Then there's hypomobility, and this requires mobilization or manipulations, and I am unable to teach you how to mobilize the spine because that's not considered part of your domain. Now, when you get out there, your supervising PT may show you some techniques and say it's okay for you to do them, but I can't teach you them, those to you, except to say if your patient is hypomobile, yeah, then you want to do those. They need to have those done, and your PT would be the one to do them. With muscle and soft tissue lesions, you're going to treat those the same way you would teach an injury to any other muscle or ligament, muscle or soft tissue lesion in the arm or the leg. Okay. During the acute phase, you're going to use modalities to decrease pain. You're going to start with some gentle isometrics, and then you're going to do some range of motion, in pain-free range of motion, right? And then postural pain syndrome, and we talked about that last week, so you know what to do there as well. So what I want to do is show you some videos, and you have access to these videos on, if you look in the front of your book, you have a code there. Okay, and if you go on the Davis Plus website, you'll be able to access a lot of different things. But what we're going to do is watch the videos, and then we're going to practice these, okay? Okay. So what they're using here is a device that can be purchased that it blows up like a blood pressure cuff, and then you pump it up to about 20 millimeters of mercury, have them watch the needle as they perform some exercises to stimulate the deep flexors of the muscles, or of the cervical spine. You can do the same thing with a blood pressure cuff. And what I've heard about these devices that you can purchase is they get holes really easily. So a blood pressure cuff is probably a better idea in the clinic anyway.
Train the patient to activate the deep segmental cervical flexor muscles without the overriding global muscles, such as the sternocleidomastoid. You may use a pressure biofeedback unit to help the patient learn control. Teach the patient to increase the pressure in 2 millimeter increments and hold the contraction for 10 seconds.
Okay. So remember we talked about how doing a chin tuck activates the deep flexors of the muscles of the cervical spine, and how you don't want to do them too hard because they can cause a headache. The other reason you don't want to do them too hard is because you'll activate the SCM, and with a forward head position, the SCM is already short. You don't want to strengthen it further. Okay, so you put them in a neutral spine and then activate the deep flexors without activating the SCM. And by just making the needle move 2 millimeters of mercury means that you're just getting a very slight cervical flexion going on. I'm going to do several of them and then we'll practice. Okay, this one is activating transverse abdominis.
Train the patient to activate the deep segmental transversus abdominis muscle without the overriding global oblique abdominal muscles. Palpate the transversus medial to the anterior superior iliac spine. It feels like a tense sheet of plastic wrap when contracting. The internal oblique feels like a bulge under the fingers. Have the patient contract after exhaling with the instruction to draw your belly button toward your spine. Do not allow substitutions, such as sucking in and lifting the rib cage or pelvic tilts. Also, make sure the contraction is gentle. The internal oblique contracts with too much effort.
So you should feel a tensing but not a bulging underneath your fingers.
The quadruped position may be easier for instruction and practice. Contracting the pelvic floor muscles may facilitate the transversus abdominis contraction.
And then this is activating the multifidi.
Palpate the multifidus muscle lateral to the spinous processes in the lumbar spine and compare bilaterally and segmentally. Ask the patient to swell the muscle out against your pressure. This may be facilitated with the transversus drawing in maneuver or by contracting the pelvic floor.
Do you hear that? Contracting the pelvic floor.
With the patient on his or her side, gentle resistance to rotation may facilitate a contraction.
Okay. So let's work on those three things. And I want you to grab a partner, and I only want one group of three. I think we'll have one group of three.
Should be even. No, it's Chelsea left. Oh, never mind, Robin's back, never mind. Come on, Angie.
No, I called it.
No.
I called dibs on the infection. Don't take
Respect the dip.
I said, I called it. Oh, can't do nothing.
You gotta respect it.
Can't do nothing.
We're seeing us trying to look at
Fill this. I know that. Make him suck in. Oh, yeah.
I'm having heartburn right now.
Okay, I've got blood pressure cuffs over here. You wanna?
Sorry. Yeah, I got sick when I left. I was fine the whole time, and then I got sick when I left. I think I was dizzy, I thought I was gonna pass out.
If there aren't enough blood pressure cuffs to go around, then go on to the next one, which is a transverse abdominis.
At first I thought she was genuinely concerned, like, I really thought she was but she also was. I'm not scared to fail. I'm not as dumb as I look.
Yeah, okay. Yeah.
When I blow out.
Yeah.
It's a bulge, so don't do The bulge is the oblique. That's not what I meant. Angie, not what I meant.
Okay, what do I see?
It's only supposed to be like a tooth right there. It's not tooth right. Don't do it afterwards.
Well, I'm trying to pull my stomach.
Yeah.
And once they can stabilize and hold it, then we're gonna add in some more exercises.
Yeah, I feel something.
I can feel it.
Yeah, I can feel it too. I just don't know if it's the right muscle. Okay, then it's she said, like, oblique. Jiminy Christmas. That's not what I'm getting at. Angie.
You just tuck it far enough to get to, right, I think that's the point. If you're only doing.
I don't know if I'm feeling the oblique or the transverse.
I didn't choose that's a bulge.
It's not what I meant.
Wait a second, I can't.
Not what I meant.
Oh, it's farther down. We were way up here.
Yeah.
Yeah.
I was like, yeah, I thought I felt it up there.
I did like 3 or 4 weird motion.
I mean, it's like, how do you
Yeah, you're not doing a whole lot.
Far.
You gotta keep your head nice and still. Okay, you really a little bit to jump.
Bring your belly button towards your back. So put your bring your belly button towards your back.
Okay, I felt
That
it.
was too far.
It's hard not to do
It
it.
is.
Right there. Yeah, a little back off. But
Right there, right there.
just like that.
Hold it there for 10 seconds.
But you don't want to.
No,
Different policy, I'm sorry.
It is, it really is. You just wanna go, we've been taught to go.
We've been taught to do big motions. We have to,
Let me root around.
we have to override that,
Just
just
so
so
they
they
know,
move differently.
And that's for stability. You don't have stable where it's abdominal.
And once you get past the acute phase with some of the biases, then you're gonna get teaching skills. Okay?
Oh, I think that's too much. Don't do something.
Not raising my hand.
Do less. Do less. Don't squeeze so hard.
yeah, so just give it a little.
Now you're actually
It is hard.
Take a moment.
Oh, yeah, my soul.
Yeah, it's not personal. I like personal.
Oh, yeah, I called him and he said, yeah.
You want
Yeah.
this.
And it's supposed to,
And then,
Okay, so do it again.
It's okay, you can go, you can go.
Oh, yeah.
Yeah, let me not do it.
But I go to bed.
Because I hadn't rolled over.
Yeah, I can feel it.
Yeah. Yeah.
You want a picture?
it's kind of one of those proper positions.
I was trying to go around like the library, but I don't think she got anything. So yeah, I don't know.
There you go. There, yeah, right there. No, you didn't know, you did it.
Yeah, we did without it.
Don't have any more.
I'll sit here and massage. I know. Yeah. Well, his like rose up like. Right now he's trying to.
Yeah, just act like you want to grab it. It's just tight.
I think just like that tightening. I forgot
Here, because we'll check the diagram out here, and so they don't run in between.
No, yeah, got the contraction pelvic floor.
Do you have any?
Like, these are got next.
Don't poop your pants.
Just like up a ward. And I knew that.
I'm not doing it smart. That's what we're like, oh, I get it.
I usually give you up.
That's fair.
This is August, we were both doing it.
Oh, well, they have sore spots on my back. Yes, everywhere.
He's very thorough.
Okay.
Yes. Look at it. Read that. Read that.
He was like straddling, but he was like over the top.
Hold on a second.
Are you doing our thing?
That's what you're looking for. That tells you that you're activating the multiple. You want to train them how to.
Okay, Cleopatra. Because she's
Training them how
What is she?
See, I thought you were out.
Rotating your head, and it'll
start out.
Yes, yes, that's true. How'd you break your
I was activated. I was training them.
You're doing good.
I was supposed to know it.
Spin it around.
It's cool.
So where do you put it? You put it under the
Yeah, so here's your thingy.
Are you?
Here you go.
What page is it?
What you can do.
Stop moving, Angie.
Being tortured. What you can do is use the side of your hand rather than.
I can barely.
Sorry.
I can't function.
I keep, every time I breathe it moves.
Stop breathing.
Pull your belly button toward it.
Then hold it.
There, that's better. That's better. I got told this morning I don't have very good hip
How hard is
things.
it?
Good thing.
Yeah. I can't, I just forgot what I learned this morning.
Good thing.
That's so weird.
Very excited.
What's wrong with it? You felt it? What's wrong with it?
Do you pump it up?
Some of that, so there's a little bit of air in there.
Yeah.
Mine was like 40, but.
Yeah.
It was, I started off at 20.
Yeah, when you hold down,
Yeah.
it's like 40.
There wasn't any in there when I first went and got my hair. Even Kayla. Is it under your neck? Liars!
Roll over. Good.
Yeah.
You got a heavy head.
I do.
Not big old girl.
Thank you. A little college. I wish. That's good.
Okay,
Hurts my neck a little.
so let's watch this next video.
And then what are you supposed to do?
Once the patient learns to activate the core cervical flexor muscles, move on to develop and control while superimposing extremity motions. Begin with repetitive shoulder flexion to 90 degrees and abduction to 90 degrees, as well as external rotation with arms at the side.
Oh, that scared me. I think I punctured a lung. I'm such a scaredy cat.
And you're gonna do that while holding that
Perform these motions unilaterally.
stabilization.
Oh, okay.
What, the neck and the multipedi and the.
All of them or just the trans?
Both, but right now they're doing the neck.
Bilaterally. Or alternately. When the patient can control these motions for several minutes with no increase in symptoms, progress to bilateral shoulder flexion, abduction, and diagonal patterns incorporating flexion, abduction, and external rotation, all to end range.
Look at those PNF patterns.
D1 flexion. Six.
Okay, go ahead and practice that real quick.
What is chin tuck? Basically,
I can't put it over.
like the chin tuck.
No, come back.
You don't have to go all the way.
First hold it.
Lisa, should we stop that? Hey.
If they want to fast forward through it, they can. You can when you go watch it again.
My butt was just like that.
Did he play a video?
That's
Great. Whatever we just did there.
Okay, this we do better than the rest.
Okay, you're on video.
Look at this.
Can you play the video again?
Once the patient can activate the core cervical flexor muscles, move on to developing control while superimposing extremity motions. Begin with repetitive shoulder flexion to 90 degrees and abduction
So
to
the
90
knees
degrees,
are
as
bent
well as
up.
external rotation with arms at the side.
So let me get that two pressure point.
These exercises are also in your book, in chapter 16.
Perform these motions bilaterally.
Do your chin tuck while you do it.
Oh, no, I was
Bilaterally.
Okay, therapists, you need to be checking that they're maintaining their stabilization
Or
while they
alternate.
do those exercises.
I'll picture.
So how are you gonna do that?
See that they're pushing their.
There's some in Sandy's.
Palpation? Yep. You need to have your hands on and make sure that they're maintaining
Like behind there.
Just Sandy's locker, she has.
cervical stabilization
I don't know, but it's not
without
locked.
activating the SCM.
It's one of the first
So we
ones
need
right
to have our
beside.
hand underneath our
You need
neck?
to have.
From the
have it
side or
under
from the
there.
back?
And on the SCM,
So from the back, basically?
yeah.
Oh, that's part of it.
I don't remember how much it is.
I do too.
And only go to
I
90.
don't care. I'm very trusting of other people. It's really a downfall.
Well, I can't do this.
We need to talk about doing it.
Yeah, you're done for like 5 minutes.
So if they lose their stabilization, take them back.
Did you find it, Katie?
Get the stabilization going again and help them by talking to them and facilitating them with tactily, verbally, to maintain that stabilization while they move. If they lose it, come back to where they lose it and start again. Don't let them move unless they can keep that stabilization.
Just relax.
I'm trying. I'm like squeezing my legs too. Oh yeah, I'm supposed
You're probably good.
Going down is fine.
Not something you really do much, so.
Yeah.
Oh, that's hard.
It's hard.
Make sure you have the opportunity to be the patient and the therapist.
I have right side. It's hard to do. Go around your neck and then with the sore button.
I'm gonna go ahead and show the next video. And this is stabilization emphasizing extension.
Once the patient learns to activate the core cervical flexor muscles, progress to developing control of the extensor muscles while superimposing extremity motions. Begin in the prone position with cervical retraction. Have the patient lift his or her head off the table and maintain it in a neutral position.
Okay. Well, I think it does.
Then add arm movement to the head lifts, initially shoulder lateral rotation and scapular adduction with the arms at the sides.
So they're gonna maintain, they're gonna lift their head and maintain neutral, and then they're gonna
Progress to
add
having the arms
scapular,
at 90-90
a
with horizontal
deduction
abduction
and
and
external
scapular
rotation.
adduction.
How is this possible without firing your SCM?
You just have to be very,
When the
very,
patient can control their
It
head
has to be
posture
very
while
small.
performing these motions for several minutes with
But I
no
mean, you're
increase
gonna
in symptoms,
fire
progress to
it, but
repetitions
you're
of shoulder
trying
elevation
to
at full range,
Not
make
as
sure they
much.
stabilize first. okay?
Shoulder lateral rotation in the 90-degree abducted position with elbows extended and shoulder horizontal abduction and scapular adduction with elbows extended.
Between this and like scapular stiffness.
Like squeeze your legs together.
And their heads. On top of hold your head up. Like you first, sure.
This shows a progression, okay?
So
They have to be able to do
the one first.
the easier things well before you progress them to the more difficult things.
Arms to your side.
Arms to your side, face down.
Are you with me, Robin?
Right now we're just practicing. First, you're just gonna lift your head. Well, not more, just about that same amount of pressure you practiced earlier. Like right there, I think. Just lift your and then I think you go out to
No, I'm letting my head down.
plank again.
See that girl?
That was the first one.
You're kind of not mad though.
Head up. Come on.
4:30.
Once the patient learns to activate the core cervical flexor muscles, he learns to develop control of the extensor muscles while superimposing extremity motions. Begin the prone position with cervical retraction. Have the patient lift his or her head off the table and maintain it in a neutral position. Then add arm movement to the head lifts, initially shoulder lateral rotation and scapular adduction with the arms at the sides.
So look what she's doing. She's like rolling her arms.
External
Progress to
rotation.
having the arms at 90 degrees with horizontal abduction and scapular